Is it possible to apply the capsule laser technology in patients with dense cataract and small pupil? Why not? Let's watch this case together. I started with two paracentesis, 2.4 clear core incision. Look at the pupil size, it's around 2 or 2.5 millimeter. In this case, I choose to apply the capsule laser, but I should dilate the pupil using the Mallogen ring. So I inject 1.4 sodium hyaluronate to form the antechamber to implant the Mallogen ring, as we can see. Then I remove and wash out the 1.4 sodium hyaluronate using the bimanual irrigation aspiration to be sure there is no viscoelastic in the anterior chamber in order to stain the anterior capsule properly using the capsule blue. Here is applying the HPMC over the cornea before injecting the Trypan 0.4% capsule blue. Then after 1 minute, wash out the capsule blue using also the bimanual irrigation aspiration as it's clear. Look at the homogeneous staining of the anterior capsule and look at this central trypan landmark. It's very clear. So now applying the capsule laser circle, which should be concentric with the TCL. Look to the beautiful fast 360 degrees, well centered, well sized, beautiful cutting of the anterior capsule. It's 5.4 millimeter diameter of the capsular rhexis. Then doing the hydrode dissection, because of this cataract is very dense, it's difficult to see the posterior wave. However, you feel the nucleus comes up while doing the hydrode dissection, which is a good sign for the posterior wave. So look to the beautiful rotation of the nucleus, which is a sign of complete hydrode dissection. Now it's the time for chopping this dense nucleus. As we can see, here is a horizontal chop. Hold the nucleus, then split it in two halves. Then you can hold each half and chop it into small fragments. Then you can continue chop and chop until remove all of this dense cataract. However, it is crucial step while emulsification of this dense nucleus to multiple use of dispersive OVD in order to protect the back of the cornea, as we need to use a high ultrasonic energy in order to emulsify this dense cataract. Here you can see I'm injecting the dispersive viscoelastic to protect the back of the cornea. Now continue chopping. As we can see, chop and chop. Here is the last fragments of this dense nucleus. After that, we can see the posterior cortical and epinucleus shell. It is just gentle aspiration of this shell, and you will see there is no cortex, so no need to use the bimanual irrigation aspiration. After that, just using the cohesive OVD to form the capsular bag and antechamber to implant 3-piece IOL. Actually, I used to implant 3 pieces IOL haptics in the sulcus and optic, capturing the capsular rhexis because there was mild phacodonosis while examining this patient on the slit lamp. So here you can see the haptics in the sulcus and capturing the capsular rhexis with optic is very clear. Now, before washing the viscoelastic, it's the time to remove the Mallogen expander ring, then bimanual irrigation aspiration to wash out the viscoelastic anterior and behind the IOL, then doing stromal hydration, and thank you for watching.